Hi everyone, how's it going? My name's Han. I'm an advanced cardiac imaging fellow at University of Pennsylvania. I'd like to thank the Cleveland Clinic and all the faculty for inviting me. It's much better weather here than Philadelphia. But my presentation today, maybe not quite structural, but very interesting case I thought, and pretty images hopefully. But high-risk aortic reconstruction, mitral valve repair in a patient with rheumatoid arthritis. So this case starts a 67-year-old woman. She has a history of pretty significant rheumatoid arthritis. She's on DMARDs, the disease-modifying therapies, CTLA-4 inhibitor, and leflunomide. So she also has history of interstitial lung disease on room oxygen, so that kind of more mild severity. Presented to the ER with a couple days of progressive dyspnea and cough. She had developed recurrent pleural effusions on her right side in the last 2 to 3 months prior, and no previous cardiac history that we know of. Came into ER tachycardic, EKG down here, it's just some nonspecific ST changes. On room air, and with some signs of mild pulmonary edema and maybe that right pleural effusion kind of building up again. Nothing in her white count, kind of low normal hemoglobin. So this is her transthoracic echo. See kind of low normal, preserved LV function. Here are the measurements in terms of LV diameters. So kind of zooming in on the aortic valve here. So here zooming in on the aortic valve is color Doppler. This kind of eccentric, possibly, aortic regurgitation. Here are some measurements for her aortic root and her LVOT diameter. So if we kind of go back, maybe not that clear sort of on the transthoracic right now if there's any kind of structural issue with the valve itself, but we'll sort of keep going on the images. Zoomed out again, very eccentric jet. And then sort of zooming the box in, also moderate to severe MR, at least on this parasternal long view, maybe eccentric. We'll sort of move forward. This is just kind of a shot of the ascending, if we can see here, a very turbulent jet as well. This is her parasternal short. Hopefully these play. This is a zoom in on our parasternal short. Probably trileaflet. Maybe a zone of non-coaptation. These are 4-chamber views. Let's see if this moves. And this is her 5-chamber. Again, a very eccentric AI jet. And then that moderate to severe MR. Biatrial dilatation, maybe a very small pleural effusion. These are her numbers for her LVOT and pressure half time about 250 to 300. This is looking at her, this kind of overlapped here. This is her aortic arch. In terms of a little bit of flow reversal. All right, a couple more TT images. Here's that moderate severe MR, ERO of 0.2. So this is the official report, low normal LV function, no specific wall motion abnormalities, RV systolic function borderline, RV size was normal, they call it kind of probably severe AI, and then moderate severe MR with some mitral valve thickening. But again, kind of sort of the mechanism-wise, not so sure yet, so proceeded to do a transesophageal echo. This is our biplanar of our 4-chamber. On here, hopefully all of these play. So at Penn, for RTs, especially for these valvular cases, I think like in this morning, we like to do the biplane for the three segments of the posterior and anterior leaflets. Overall, it looked a little bit more central and functional than what we saw in the transthoracic echo.
Sorry, can I ask you the interval between the transthoracic to the, how many days or weeks between one and the other?
Oh yeah, 2 days. 2 days.
2 days.
Yep.
Thank you.
And no, maybe one like day of kind of diuresis, falling down. And so here too, I think we've seen in the early talks this morning, doing multiplanar reconstruction, looking at the 3D valve, but again, kind of a central zone, not really eccentric or any specific leaflet issue. All right, so kind of moving on to our aortic valve, which is pathology here. Here is sort of a color compare, and we can see that we see kind of more clearly here that there might be a disruption in the aortic sinus here and possibly the LVOT, and exactly kind of where we see sort of that eccentric jet kind of directed anteriorly here. Here's biplane again, and looking at sort of where that root is. There's a concern that this may be an abscess, fistula, or a pseudoaneurysm. I think this kind of delineates it a little bit more. And we're kind of trying to show here if it extends sort of more on the sort of posterior to the ascending aorta here too. Some other images, and we're doing a sweep here to try to see if the connection here, which seems to be from the LVOT upward to the sinus. And this is a view that I think we often don't use too much to interrogate the aortic valve, but kind of a 5-chamber here. You can definitely see the sinus here that's sort of abutting out. This is another 3D reconstruction, and this is sort of our short, kind of a more traditional short axis view here. These are some of our 3D EROA, I think calculated out to be about 0.3 for the mitral valve. And then here it's pretty nice, I think Dr. Gilman talked about it, where we're kind of doing 3D of the aortic root, and we're actually kind of able to sort of define the vena contracta of these two separate jets, one sort of coming in anterior, and then sort of another one kind of more central. So anyways, these all kind of calculated out to be pretty severe AI. So the official report, there's a thin outpouching of this aorta at the level of the annulus, adjacent to the non-coronary and left commissure, consistent with a pseudoaneurysm, resulting in this kind of severe eccentric AI, and also malcoaptation too, resulting resulting additional AR. And then in terms of the MR, more of a functional mechanism, we calculated 3D vena contracta to be 0.3, centrally directed, with elevated pulmonary pressures.
Can I ask a question at this point?
Yep.
So you say severe AI. So is the flow actually traversing the valve or just going back and forth into the pseudoaneurysm?
Yeah, that's a good question. So, so that we did count that sort of jet into the pseudoaneurysm as part of the AI, but there was also AI going through the valve itself with that coaptation. But I guess if you think of it that way, it may be sort of qualitatively a bit different. Surgery was consulted at this point. They wanted to do a CT to look at the coronaries, but in terms of multimodality imaging, I think this is very interesting too, to look at the root itself. So you can see here, you have this outpouching that connects from the LVOT here, sort of go up into the root. We did a 3D reconstruction here. The other thing that was important here in terms of surgical planning was that the patient with her history of rheumatoid arthritis and on disease-modifying therapy, there was any signs of coronary vasculitis, which we didn't see. So again, asymmetric aortic root aneurysm with this LVOT fistulization, or at least part of that is the mechanism for the AI. So surgical planning, this was not supposed to show up yet, but so very interdisciplinary, rheumatology, pulmonary on board for her rheumatoid arthritis and ILD. A lot of recommendations on sort of her pulmonary status in terms of her maintaining her C-spine stability during general anesthesia, keeping a low tidal volume, low PEEP for her interstitial lung disease, as well as extubating within 6 hours. So these are some measurements we actually didn't make on the initial TE that we did, but anesthesia pre-op, intra-op during the case. In terms of, maybe not here, in terms of looking at the angle and making sure that the leaflet lengths are not increased for the risk of SAM. Otherwise, the distance here, the angle was 119 degrees. The ratio of the anterior posterior leaflet was normal. And then actually not that big of a mitral annulus, measuring 3 centimeters at the major axis and 3 at the minor, which is kind of what we saw too on the CT. So this patient ended up getting a 23 Connect pericardial composite root. The surgeon had gone in and found multiple of these fistulous connections, mostly under the left cusp, left main, and the LVOT under the sinus. It was widely open to make one complete cavity before the root was put in. There's some images off bypass. And then a partial mitral ring, a 30, was placed as well with the MR. And there's still some residual, they call it residual mild, but it looks kind of more mild to moderate. Mean gradient was 6, and then the aortic valve looked fine without any paravalvular or intravalvular leak with good gradients, EF 45%. So this patient ended up, the pathology came back for this root called fibrosis, chronic inflammation consistent with healed endocarditis. So the ID team was pretty involved in this. She was in the hospital for about 1.5 weeks. They did blood cultures were negative. Carius, which is this new kind of cell-free DNA testing, was also negative. Sort of because of just how the valve itself looked on pathology, she ended up being treated with 6 weeks of pretty heavy antibiotics, daptomycin and ceftriaxone. Their ID kind of thought maybe some sort of indolent organism, actinomyces, so they want to cover everything. And then I just checked the chart a week ago, so she's been doing pretty well in her 4-month follow-up. Kind of similar mild to moderate MR with no aortic valve issues, preserved EF. All right, so this case was interesting, maybe not quite that structural, but a pretty multidisciplinary approach to a high-risk aortic root valve replacement, as well as a mitral ring for the pseudoaneurysm fistula, and which resulted in functional MR. And this multimodality imaging was crucial for the diagnosis pre-op and for surgical planning.
Thanks very much.
Thanks.
So we have around 15 minutes per case, so maybe a very short discussion in this case because a little bit late. The question is, should have been a homograph versus a composite for this particular case? What do you guys think should have been the surgical approach?
At the Cleveland Clinic, we would generally favor a homograph for active endocarditis in particular. It wasn't clear if this was active, but the reasons we like a homograph are two. One, they're very compliant and can be used more or less to conform to an abscess cavity. And two, we do believe that there is some better resistance to infection with a homograft than with the Connect graft. The Connect graft is basically a bioprosthetic valve with an attached Dacron graft. But clearly, that was a very, very nice result.
Just a question for you, sort of correlate the surgical findings with the imaging and the nomenclature. So abscess is contained, pseudoaneurysm is open at one end, typically the LVOT and the intervalvular fibrosa. But a fistula is open at both ends, and it has to recannulate into the aorta. And generally, it becomes less pulsatile at that point because you have an open channel. So you said fistula and pseudoaneurysm, but it's hard to be both. So can you describe exactly, was there a connection to the aorta, or was this just a pseudoaneurysm?
So based on the initial imaging, it looked just like a pseudoaneurysm. But what they reported during the surgery was that they actually saw fistulous connections.
Okay.
The one question I have quickly is for maybe our surgeon here, Dr. Gilnoff. Looking at this case, repairing this mitral and now having mild to moderate, where it looked like the leaflet's quite thickened, and this could potentially progress again. Of course, it's already a big surgery for the aortic position. What were your thoughts on when you saw that choice to repair?
I think the question was, what about the mitral valve, basically? I had thought initially that the mitral regurgitation was coming from a hole in the anterior leaflet of the mitral valve near the fibrous curtain, although where was the leak from the mitral valve? Was it actually central as it looked initially, or was there a defect in the mitral valve itself?
No, so it looked like an initial defect on transthoracic, but on TE it looked functional. Thickened by leaflet.
So it looked central?
Yeah.
Okay, well then I think what they probably did is place an undersized ring. And mild to moderate, not ideal, but I certainly would not go back for it at the time of surgery.
Yeah.